Lab diagnosis of megaloblastic anemia. Megaloblastic anemia diagnostic tests include screening test, specific test, and which is used to identify the vitamin deficiency and underlying causes. So screening tests for megaloblastic anemia include the CBC, or complete blood count or full blood count, reticulocyte count, white blood cell manual differential, and serum bilirubin and lactate dehydrogenase. As we remember that megaloblastic anemia is a component of hemolytic anemia. So that's why it is also very essential to measure or to assess lactate dehydrogenase and bilirubin as well, because this remains a component of hemolytic anemia. Lactic acid dehydrogenase is very important for hemolytic anemia assessment, as well as serum bilirubin concentration. So CBC or FBC and reticulocyte counts. So there will be slightly macrocytosis as the earliest sign, with a decreased hemoglobin and hematocrit, pancytopenia, reticulocytopenia in uncomplicated megaloblastic anemias. So the hemoglobin is less than 7, and with the megaloblastic heteroblast on peripheral blood smear, MCV usually it is high, up to 150 femtoliter, and also elevated RDW and MCH and normal MCHC. You can see that MCH can elevate, but MCHC will be normal because the cell is very large. Amount of hemoglobin in each cell is normal, is relatively normal comparing to the size of the cell, but it is abnormal. I mean, it is high comparing to the amount of cell. It is high because the cell is large. It contains a lot of hemoglobin, but normal MCHC because concentration is going to be normal because the cell is also large. Comparing the cell and the content, the cell is large and the amount of hemoglobin is high. So that's why MCH is high, but MCHC will be normal because of the concentration that remains in normal range because the cell is also very large. So RDW is also high, which indicates that you have what you call bimodal or bimorphic RBC. You find two categories of red blood cells. Some of them are big, others are normal sized. So that will increase RDW ratio. So ovomacrocyte is also another characteristic, and hypersegmented neutrophils, because vitamin B12 and folic acid are very important for white blood cell maturation. So that's why hypersegmentation of neutrophil, which is abnormality, where neutrophil could show more than 6 lobes, that is one of the abnormalities affecting white blood cells in folic acid deficiency. Polychromasia is absent on peripheral blood due to impaired cell production, and teardrop cell RBC fragments, microspherocytes will also increase, which in fact shows that this condition is associated with the hemolysis. That's why you would find the microspherocytes and RBC fragments, as well as also schistocytes, which are associated with hemolysis. So keep in mind that megaloblastic anemia is a component of hemolytic anemia, and that because these are the fragments of RBC, this will reduce or will lower MCV paradoxically, because even if we can always claim that MCV is high due to megaloblastic anemia, but because of the fragments as a result of hemolysis, this can even reduce or can lower MCV. So nucleated RBC, whole jelly bodies, basophilic stipplings, and carboat ring may also be present on the peripheral blood smear. Maybe I'll show you all these stipplings or these inclusion bodies, the whole jelly bodies, which is of course the remnant of the nucleus, basophilic stipplings, which is of course the remnant of RNA and the ribosomes. We'll see them, especially like this one. This one is known as whole jelly body. This is a small dot which indicates a small fragment of the nucleus when it's being ejected. So you can find also teardrop cells. These are the teardrop cells. We have the ovomacrocytes, all of them. of macrocytes, and also normal cells are still there. So if you look at this peripheral blood smear, you will exactly conclude that there is high RDW, because you will find bimodal population, there are small cells and very big cells, even like 3 times of the small ones. So that will increase the RDW, or red cell distribution width. And of course, as you can see here also, there are many cells, including even the fragments or schistocytes, teardrop cells, schistocytes, and even microspherocytes, like the small ones you see here. And like this one is the microspherocytes, this one, and this one, they are spherocytes. So spherocytes are those cells that are very dense and dark and very small. So those are known as microspherocytes, and also schistocytes, which are fragments of RBC due to hemolysis. So apart from the peripheral blood smear, we can also assess bilirubin and lactate dehydrogenase. This is very important because bilirubin is, of course, a product of hemolysis, especially extravascular hemolysis. So lactate dehydrogenase is also another product of hemolysis because ADH1 is abundant in red blood cells, and when the following hemolysis, it is always high in plasma. Megaloblastic anemia is constant hemolytic due to ineffective hematopoiesis, leading to low reticulocyte counts. And you understand also why low reticulocyte counts. It is because this is what we call ineffective hematopoiesis, which means even a cell that will be produced, when the cell is still in production, or it is still a precursor or a blast, it will be destroyed by the bone marrow macrophages because it is abnormal cell. That's what we call ineffective hematopoiesis. So ineffective hematopoiesis is that hematopoiesis is incomplete because there is destruction of cells even before they mature, before they reach peripheral blood. Signs of hemolysis include elevated total bilirubin and direct bilirubin, and also increased lactate dehydrogenase. So now we have the constellation of findings. The constellation of findings include macrocytic anemia, moderate to marked pancytopenia, reticulocytopenia, ovomacrocytes, and hypersegmented neutrophils, plus increased levels of total bilirubin and direct bilirubin, right? And lactate dehydrogenase. So these are the constellation findings in megaloblastic anemia. Macrocytic cells, marked pancytopenia, reticulocytopenia, ovomacrocytes, hypersegmented neutrophils, and elevated levels of bilirubins and lactate dehydrogenase. So when you see this justifies further testing to confirm the diagnosis of megaloblastic anemia and to determine also the outcome. So what are the further testing or specific testing in megaloblastic anemia? It is bone marrow examination. I would like to ask, why do we need bone marrow examination in megaloblastic anemia? So the floor is yours. Why do we need bone marrow examination? And because bone marrow examination is not performed in any other anemia except megaloblastic anemia, why do we require bone marrow examination for this? Who can answer that question? Why bone marrow examination in megaloblastic anemia?
Can I try?
Yes, please.
I think because most of the bone marrow being the specific or the site where blood maturation cells takes place, blood formation. So the bone marrow is where the megaloblastic anemia, you will be seeing the blast cells which are not fully matured in the peripheral blood smear. I think that's why it's most likely to diagnose through bone marrow examination.
One more examination. Okay, thank you so
Yeah.
much. Someone else can try, maybe one person, and we discuss together why. This is a very important thing to know. The reason why we need bone marrow examination for megaloblastic anemia. Someone is writing something to diagnose effective, ineffective erythrocytes. Already they're ineffective. Yes, true. So let me shed some light on it. We need megaloblastic anemia. I mean, we need bone marrow examination in megaloblastic anemia because of what I said at the beginning. Sometimes we can confuse megaloblastic anemia with myelodysplastic syndrome because of one important thing, which is known as nuclear cytoplasmic asynchrony. So, because in megaloblastic anemia, we also have this asynchrony. Asynchrony means like imbalance in growth, in maturation. The nucleus will not mature, the cytoplasm will mature alone. And this is what you call asynchrony. So, which means that nucleus will lag behind the cytoplasm because of impaired DNA synthesis. That will take a long time for the nucleus to grow. So, because most features of megaloblastic anemia can be similar to myelodysplastic syndrome, and you know myelodysplastic syndrome is a very aggressive disease, so we have to do bone marrow examination in order to rule out the possibility of megaloblastic anemia. I mean myelodysplastic syndrome, right? Because all of them are plastic and like something like that. So myelodysplastic syndrome, it is a very aggressive disease, but which is characterized by almost similar findings as megaloblastic anemia. But when you perform bone marrow examination, I will show you how megaloblastic anemia, myelodysplastic syndrome looks like under microscope. It is characterized by multiple nucleated red blood cell precursor cells like blast. They are multinucleated. They are main nuclear budding, nuclear bleeding, nuclear ring, and many vacuolation and many things. Very, very abnormal characteristics. But what they share in common? It is this one: nuclear cytoplasmic asynchrony and megaloblastoid features, which means in both MDS and myelodysplastic and the megaloblastic anemia, we will have big RBCs or giant red blood cells or macrocytic cells. They are found in both diseases. And the second thing, they are also showing the nuclear cytoplasmic asynchrony. So if you do, for example, and also the second thing that is also very important, in megaloblastic anemia and also in myelodysplastic syndrome, in both conditions, there is hemolysis. There is marked hemolysis. And because of that, the findings of LDH high, bilirubin high will be similar in both conditions. So you can see that most findings in MDS and megaloblastic anemia are similar, except what you can do to confirm is to do bone marrow examination in order to rule out the possibility of megaloblastic, because megaloblastic anemia is very aggressive and it requires aggressive treatment. But of course, before you do that, you have to measure vitamin B12 and folic acid, because in MDS they are normal. They are not low. They are normal. So we can maybe sometimes guess from that, but 100% in order to be sure, we have to do bone marrow.